Hi, everyone. It's Stephanie with the Patient Story, and I'm so thrilled to bring our guest today for you all at home watching and reading this, Dr. Rafael Fonseca, who's the Interim Executive Director for Mayo Clinic at large. Quite a big title. Dr. Fonseca, welcome.
Stephanie, thank you very much for the opportunity. I'm delighted to be with you all here today.
Wonderful. And we will get started shortly, but just to remind people, today we're really focused on, of course, multiple myeloma, and there are just so many different areas of research in terms of new treatments and therapies, and that's what we're really focused on today. And to take out all that medical jargon, to really, speak to the people, so to speak. And before we jump into all of that discussion, Dr. Fonseca, can you just describe a little bit more about yourself and the work that you do?
Yes, happy to do that. So as you heard, I'm based at Mayo Clinic in Arizona, and I've been practicing in the field of multiple myeloma now for over 23 years. That, has been my career at Mayo Clinic. I have a clinical practice where I see patients and monitor patients with myeloma, and I have also a research laboratory. So I spend all of my academic time just caring for myeloma patients and doing research around the disease. And of course, very fortunate to have lived through the past, 10 and 15 years where we have seen the explosion of agents that have come forward for the treatment of this disease, which I know we will discuss in greater detail here.
Perfect. And, we were lucky enough to be able to talk to you back in 2019 about the basics. And so for anyone who's interested in that, we'll drop a link for that as well. But so Dr. Fonseca, let's start with the first or primary or frontline therapy. As you mentioned, explosion for, the relapse refractory segment of the population. But we want to discuss first when someone's newly diagnosed, what they're typically looking at. So we'll cover that, right now. There's the three classes, so proteasome inhibitors, you have IMiDs, and you have monoclonal antibodies, which sounds daunting when you're just overwhelmed by diagnosis. So can you break down in sort of human terms, what those mean, what role they play in the treatment of new myeloma patients?
Happy to do that. So, when we face a situation of someone who has a newly diagnosed multiple myeloma, we have to make some early determinations regarding the best treatment pathway for that person. There are two general ways, which to this day still, remain, and that is, do you think, or will this person be a good candidate for a stem cell transplant? Because a lot of what we do, comes after that decision is made, and it's not a final decision, but it's just an initial assessment as to whether someone can go through a transplant or not. When we do that determination, then usually we come out with a plan that will include the first phase of treatment. We use the term induction, but it's just really the first phase of treatment. And that's the initial process by which we want to make sure we clean the person's body from as much myeloma as possible, and certainly prevent any additional complications if the person already is experiencing complications, from the multiple myeloma. Now, you were alluding to the name, so usually we use at least 3 and very soon 4 drugs for the first treatment of myeloma. So we use this medication cocktails. People that hear us, if they start wondering what is it that they use, so we use a lot of what we call small molecules. And these are treatments that, even though they're anti-cancer treatments, they don't really fall into what people, traditionally would think of as chemotherapy. So these are not drugs that would cause hair loss or nausea or vomiting. It's not to say they don't have side effects, and they have important side effects we need to recognize, but they use a little bit different from what normally one thinks about with chemotherapy. Now, for the average, individual, this means a combination of injections and pills. The antibodies, as you mentioned, daratumumab being the prototype for that, is injectable, and it can be given under the skin. So it's a subcutaneous administration. We have another class of drugs that are called the proteasome inhibitors, and those are mostly also injectable. One of them, carfilzomib, can be used as intravenous, and then bortezomib is subcutaneous, and the rest is done with pills. So there's usually 3, if not 4 drugs that are going to be used up front. In addition, we have to use a number of medicines that are preventive. So they prevent complications that would arise from some of this pills, and they include antivirals and antibiotics, and also some of the medications increase the risk of someone forming a blood clot. So there's some blood thinning type medications that are used to decrease the risk of that happening. Now, for a person who's facing treatment, they should know that this is obviously with intent of keeping the disease under very good control. But in most situations, we will try to go to a very, very deep response. 25 years ago, and when I was in training, we used to say, well, control is okay, and we're just going to keep, things under a better perspective. But now we know that we have to go for the deepest response possible. In fact, we measure that with more sophisticated tools. We're talking about things such as MRD testing as well, too. And the reason we do that is because that seems to translate into better long-term outcomes. So that's, part of what we are doing. And again, if the person is going through a transplant, we start planning on that from the get-go. But the idea is to get the disease under better control. And just lastly, if someone who's hearing us says, well, I'm about quality and quantity, the good news in myeloma, they both go hand in hand. So if you're able to deliver an effective treatment and you do so safely without much in the way of complications, you're going to gain both in quality as well as in quantity of life.
Thank you so much for that. I know it's a lot to go through. You were talking about there's so many different sort of paths here. I know there are different combinations. You talked about the transplant. How do you determine what path, a patient should go down? And I know you're saying you're trying to go for the deeper responses, but what comes to mind first when doctors are making these decisions for each patient?
As we're making the decision, we realize that every single situation is unique, and that could be said to be cliche, but it's absolutely true. So when we see a patient, we start looking at their disease biology. So we start looking at many factors, including the genetic makeup of those cells that we're going to be treating. It's part of our standard testing. We look at what we call comorbidities. So we want to understand whether heart disease or diabetes or lung disease will create problems as we think about treatment. And then we think about other factors such as, wellness, how fit the person is, how able they are to engage on physical activities, as well as their social environment. I mean, if we see a patient right from the moment we walk into a room, we're thinking, is this someone who can be coming to the treatment center? Do they have issues with transportation and so forth? And it is at the end of all of this that we put all of that information together and say, for this particular person, this might be the best treatment. Now, oftentimes we use similar treatments even for different groups of patients, but I can tell you almost every single regimen has some permutation or some change that makes it very unique for that person. And that could be in the form of dosing, could be in the form of schedule. It could be a different choice for, some particular reason. So we really cannot do it in a cookie cutter way, if you may. Every patient has to be treated individually.